Good afternoon and welcome to SSMC Answers. My name is Matt Getman, Chief Medical Officer here at SSMC, and I'm thrilled that you've joined the program. Today we will be having a great conversation with Mustaqim Siddiqui, who is our Chair of Hematology. A little bit about SSMC. SSMC is the biggest hospital in the UAE and is dedicated to treating patients with serious and complex medical problems. We believe in delivering holistic care, which is dedicated to the mind, the body, and the spirit. And we also want to provide comprehensive care to patients so that they can have a destination medical center experience. Each session, we invite one of our staff members again to share their experiences with a common medical problem. We want to do this to, again, focus on a holistic approach and to also give families and patients alike information about common medical problems and things that they might potentially do for prevention. Yesterday was actually World Blood Cancer Awareness Day across the entire planet. So we're happy today to build off of that and have a great conversation again with Dr. Mustaqim Siddiqui. We're so glad that you've joined the program today. Tell us a little bit about your practice and a little bit about your background.
Yeah, thanks, Dr. Getman, and thank you for having me. I'm excited to be part of bringing awareness to blood cancers as part of the World Blood Cancer Awareness Day. So part about me is that, you know, I was born in Texas, raised in California, but I went to medical school in Pakistan. And after medical school, I did 2 years of research at Harvard and then came to Mayo Clinic in Rochester, Minnesota. Did my residency and my fellowship there. And the reason I bring all that up is because it was actually in medical school where I began to get an interest in hematology and malignancies. And then when I was in Boston, I did a lot of research in basic science on what happens to the immune system when a malignancy occurs. And that carried over into my residency and my fellowship, and of course I stayed on staff. And as a hematologist on staff, my practice is really around treating blood cancers. And initially, of course, we used chemotherapy. But at least for me personally, it's great to see things become full circle, because 20 years ago when I was in a lab in Boston, I was studying the immune system. Now, as part of treatment for blood cancers, we're actually using drugs that enhance the immune system to fight cancer, specifically blood cancers. So from that perspective, that's a little bit about me and my practice. I focus on blood cancers, specifically multiple myeloma, leukemias, and lymphomas. And those are the more common blood cancers that are diagnosed.
Well, I really want to get into the blood cancer discussion, but let's just take a step back for the audience and just talk a little bit about blood.
Yeah. The
components and how the cells all interact and so forth.
Absolutely. So just to make it simple, obviously blood, everyone's got it, everyone needs it, and it is a very, very complex organ. Of course, blood is manufactured for the most part in adults in the bone marrow, but the blood system also includes part of our immune system in organs called lymph nodes and the spleen. Lymph nodes and spleen are very important for immunity because they help the body identify infections, but it's also the place where diseases can start to occur, like lymphoma. So the blood is very complex, and the blood organs are very complex. And to give you just an example, you know, a red blood cell typically lives only about 90 days, which means that our bone marrow needs to continuously make new cells. So we like to think of it as a very active organ. It's just not something that you see, you know, or think of as something being very active.
So you had mentioned leukemia, lymphoma, and multiple myeloma as being the most common blood cancers.
Yeah.
So give us a little bit about what is happening when a cancer develops. What's going on to create those states?
Yeah, so this is an area of great research, trying to understand what makes a normal cell turn into an abnormal cell. And the hallmark of cancer really is the unchecked growth. We all have cells that grow and divide and replenish themselves, but there's always a control over that growth. In cancer, there's no control. And so that begins to cause disruptions across the body, whether it's crowding out normal cells, whether it's spreading to other areas. So it's that really that uncontrolled growth that all of us are trying to really understand. Now, quite honestly, we've moved into a molecular era of cancer diagnosis in the past 10 to 15 years. And that understanding of what are happening to genes, what are things happening on the molecular level that's driving this uncontrolled growth, is really getting us closer to understanding why this happens in the first place.
Okay, and I'm also guessing, in addition to the why, maybe also creating novel opportunities for therapy.
Absolutely. So we have many examples across multiple blood cancers of identification of a mutation or an abnormal gene that then a drug is developed and has great efficacy. 20 years ago, imatinib was developed for a disease called gastrointestinal stromal tumor. And it was like magic. It was the underlying problem met the very specific treatment for that genetic mutation. And it was remarkable how a lot of these tumors just shrank and completely disappeared by just the treatment with one medication by mouth. And so you take that idea and now you spread it across different cancers and you spread it across different mutations. We have lots of drugs in development that are very specific to those mutations that are really being very efficacious. They're working very well.
This is sounding a lot like a very individualized treatment plan. What are we doing here at SSMC to drive an individualized treatment plan?
Oh, it always starts with the patient first, right? It always is, what is that patient, what are their goals in terms of how they want to feel, how they want to be treated, what types of side effects are acceptable, what side effects are not. But then also the family situation, right? We have individuals who are, working and supporting others. And so we always strive to create an individualized treatment plan, keeping in mind not just only the disease, but also their wishes and their family situation. But coming to the disease specifically, we do a lot of genetic testing to understand what are the molecular issues that are driving the growth of this cancer. And there are tests that we do here at SSMC. There are tests that we'll do in Abu Dhabi. But if needed, we'll also send tests abroad to other countries, specifically places like Mayo Clinic, that will do the genetic testing for us and give us the information that we need to find the best treatment for that person.
What are the most common blood cancers in the UAE?
So the most common one that we see is lymphoma by far. Lymphoma worldwide is the most common blood cancer, followed by multiple myeloma. So these are the two more common ones. Leukemia is also quite common here, and this is where we've seen a very interesting observation. If you go to countries that have older populations, the types of leukemias that you see are of, say, AML variety, acute myelogenous leukemia. But here we have a much younger population, partly because the country itself is young, but also because those that have come from other countries are in the younger age group. In this population, we're seeing a different type of leukemia called ALL. So AML, more associated with advanced age, ALL, more associated with younger populations. So my time here in the UAE has been remarkable in the case that we've seen a lot more ALL than I did when I practiced in North America.
What do you think are some risk factors, or why are we seeing these trends for more ALL in UAE?
Yeah, well, for ALL and AML, there are no known risk factors aside from some of the more common ones you may have heard of. Smoking, exposure to certain chemicals that are used in industrial applications, such as benzenes. But aside from that, we really don't know what contributes to the development of AML or ALL. But the one thing is clear is that age is a predicting risk factor. So having a younger population, that in of itself tends to suggest to us that we're going to see more ALL than AML.
Okay. And what are the symptoms that someone might see when presenting with a blood cancer, maybe an ALL patient?
Yeah, so these patients, unfortunately, they'll start to feel fatigue. They'll feel run down. They'll feel like they don't have energy. They may also notice that they're beginning to lose weight, or they just don't have a very good appetite. And because they're not eating, they're starting to lose weight. Those are the initial signs that maybe something's not right. But if it's quite severe, or these symptoms go on for a long period of time, then people can have other issues like unexplained bleeding. and they present to the emergency room, and we do some blood tests, and we find some abnormalities.
What about lymph node enlargement?
Oh, absolutely. So depending on which disease you're investigating, lymph node enlargement can definitely be part of what happens when somebody develops these cancers. So for example, in lymphomas, one of the most common reasons people are diagnosed is because they noticed some abnormal growths underneath their skin. And a certain type of leukemia, like ALL, will also present with lymph nodes, but another type of blood cancer would not. So yes, if they're noticed and they are seen, they definitely need to be biopsied and further tests need to be done.
Now I've heard, and we learn in medical school about night sweats and being associated with blood cancer. Is that still as relevant?
Absolutely. But there's a very important distinction. It's hot out right now, so all of us probably have some level of night sweat while we sleep. And it is true, the body's temperature changes while we sleep, so we might sweat a little. But the criteria for night sweat that makes us really suspect a blood cancer is if one person is sweating so much they have to change their clothes, or they have to change their bed sheets because they've sweat so much. So a little night sweat here and there is completely normal, nothing to be worried about. But if someone is drenching their clothes to the point they need to change out of them in the middle of the night, that's a bit more concerning.
So seeing that really a significant amount of sweating, weight loss, and fatigue, those would be some things to say, better go get checked out.
It's a good idea to be seen by somebody, have a blood test, and make sure that some of these other more common issues aren't happening.
Now leukemia, are there any different presentation for leukemia?
So in general, the fatigue, the weight loss, that all is very true. But the other thing that is very common is people will develop bleeding. All of a sudden they'll have bleeding from the nose and they don't have a history of that and they don't know why. Or maybe they've developed some bleeding when they brush their teeth. Or they've developed bruising across their skin and they don't have any history of injury. So that's another sign that something's not right.
Now multiple myeloma, it has an impact on bone.
Yeah.
And some different side effects.
Yeah, absolutely. So myeloma is very unique in the blood cancers, and that is because it attacks bone. And the cells that do this arise from the bone marrow. These are cells all of us have and have an integral part in our immune system and fighting infection. But something happens to these cells where they become uncontrolled and they start eating away at bone, and they actually create holes in the bone. That is unique amongst many of the blood cancers. And what happens with people who have multiple myeloma is they actually develop bone pain. Some of the patients that I've diagnosed actually developed pain when they were working on their home, they were fixing a window, and they had to push on something real hard, but then they felt something in their back break. That's because the bone was weakened by myeloma. They just didn't know it until the bone was injured. There are other people who will have effects of bone in their leg or their arm, and they'll have pain. And when they have pain, an x-ray is done, and there they'll see a hole in the bone. That's how a lot of multiple myeloma is diagnosed.
Is there a particular pattern with how the bone destruction can happen?
It always is a hole. It always
Okay.
seems to be a hole. But is it more in the spine or in the arm or the legs? No, it actually can happen any bone. And we typically see it in larger bones such as the arms, the legs, the spine, the pelvis, but also the skull. You can actually see little holes in the bone around the skull.
So none of these symptoms and signs that you're talking about are, let's say, specific to a diagnosis.
Correct.
What are those steps that you as a hematologist offers to really cinch the diagnosis?
Well, the first is to see the patient, to see somebody, understand what's happening, what are their symptoms, and just get a very clear story behind what's happening with that person. The second then is, of course, physical exam. There are some things that we can identify on exam that are very specific to blood cancers, and two very important things come to mind. First, are there any lymph nodes or growths that are abnormal? And that you can identify by examining a person and feeling underneath their skin. And then the second is if the spleen is enlarged. Very often that gets big when when a hematologic malignancy occurs. So history, physical exam are still the mainstay of trying to understand things. But then yes, blood tests and maybe even biopsies are needed to help cinch the diagnosis.
And the biopsy would be taken of a lymph node, an enlarged lymph node?
Enlarged lymph node, an abnormal growth, even bone marrow. We will take a biopsy to get a clear sense of what's happening.
And you go to the bone marrow because that's where blood is produced.
It's the factory. It's
Yeah.
where all the blood cells are active and they come from. And that's usually the home of where the abnormality is. Now, in some cases, it starts in lymph nodes and the bone marrow is negative, and that's one of the reasons why we end up doing both of them.
What sort of treatments then do patients need to go with once they've been diagnosed?
Yeah, so it really depends on the underlying disease. There are some lymphomas that when they're diagnosed, we don't even need to treat. Those are lymphomas that are very slow growing. People will live with them for decades, and they really don't cause any harm. We know that they're abnormal, but the rate of abnormality is so small, they never actually cause problems. But then there are others where, yes, you need to get started with treatment in 1 to 2 weeks, otherwise, the patient may not do well with that disease. So it really depends on the diagnosis. In general, blood cancers do need to be treated, but knowing the difference between one blood cancer that can be observed and another that needs to be treated right away is something that we really focus on.
And it's a combination of therapy in some instances?
Absolutely. Again, the spectrum is wide. There are some conditions or diseases that we just need to treat with one drug for repeatedly, maybe for 4 weeks. And then that person is going to have a long-term remission of the condition. But then there are others that require a combination of medications, maybe 5 or 6 different medications in a combination given over months in order to get the best results.
So that would be either chemotherapy or immunotherapy as a broad class of treatment.
Correct. And
Yeah.
quite honestly, we can combine them as well. So we can add immunotherapy to chemotherapy for the best results.
And again, the immunotherapy is designed to really look at the immune system and fight cancer that way.
Absolutely. And so there's 2 main approaches here. The first is, it's actually the immune system that's the problem. So the immunotherapy is addressing the problem cells and trying to remove them from the body. But more interestingly, especially in the last 2 to 3 years, we're using immune therapy to actually get the immune system to awaken against cancer. So in that case, it's not the immune system that's the problem, but the immune system has gone to sleep and it's lost its ability to identify a cancer and kill it. The new immunotherapies that we're using now try to reawaken that immune system and identify cancer and then help the body kill it. So immunotherapy used to be just about treating the bad immune cells. Now we have both types of immune therapies.
And what's the role for radiation therapy?
Oh, radiation has a great role in hematology. There are some conditions where just 1 or 2 doses of radiation really helps somebody breathe better or take pain away from their belly. So that's one area. A second area is, and specifically for multiple myeloma, when multiple myeloma is eating away at bone and causes pain, if it's not responding to the treatments, we can use radiation to locally treat multiple myeloma. The downside is there's other areas in the body that still need to be treated. So radiation in that sense has more of a limited role. The last role for radiation is in the bone marrow transplant space, where we use radiation to prepare the body to accept new cells in the fight against a blood cancer.
Tell us more about bone marrow transplantation.
Yeah, it's a phenomenal area that really tries to harness stem cells that all of us have in our body. The stem cell is a cell that can grow in any particular direction. In some cases, it creates red blood cells. In other cases, it creates white blood cells. In other areas, it's platelets. But the whole idea here is if you have one stem cell, a very specific type, and you collect a lot of them and put them back into a person, they can then appropriately go into the right areas and make a full complement of blood. So going from one cell to a full complement of blood is the whole promise of stem cell therapy. Now, stem cell therapy in a situation where we have lymphoma, we collect cells from a person who has the lymphoma. We collect them, we freeze them, we give that person chemotherapy and then reintroduce those stem cells. We have to do that because if we don't, the chemotherapy is so strong, the body never recovers. So we have to give the stem cells for recovery. And the other type of transplant, which is allogeneic transplant, somebody else donates the stem cells. Now, yes, it is important to have them to reform the bone marrow after transplant, but there's also another really important part of that. Those cells from another person are also part of the cells that fight the recurrence of disease. So not only do you give chemotherapy to eliminate the cancer in a person, but then those donated cells from somebody else actually have an effect on preventing cancer from coming back. It's a lot more toxic. There's a lot more steps to that type of transplant, but it is very, very widely used, especially in leukemias.
Sounds very complex, but something that we've got multiple experts here
Absolutely.
at SSMC, and you're leading the charge. Tell us about our unique care capabilities.
Yeah, thank you. That's very kind of you to say. We've worked really hard to put a stem cell therapy program together, and I should add, it's not just about bone marrow transplantation. We're looking at other stem cells and other therapies that are in the category that really help restore the body's ability to fight cancer. So what we're doing here is we've set up a cell therapy lab, which is state-of-the-art. It really is one of the more impressive components of SSMC. And we've had external visitors come by to see it, tour it, and they've always been very impressed, including people from Washington, D.C. and the National Institutes of Health. When they come and see our facility, it's literally twice the size of theirs, and our capacity to help patients is much greater than even the NIH in Baltimore, Maryland. So we've built a phenomenal facility with great people at the helm. So coming to people, all of us that are here at SSMC have a strong interest in complex diseases, in managing patients that have a lot of needs, because that's what we're really good at, and we really enjoy doing that. So you marry the facilities that we've created to the people who really thrive on taking care of patients with complex needs. You've got a great combination of facility and people.
It's great to see this, really evolve and rapidly change in a short period of time. Credit to yourself and the rest of the team.
Oh, well, thank you.
Let's go to some questions that are coming in from online. One of the questions that comes in is, are there any genetic or hereditary factors that increase the likelihood of developing a blood cancer?
So the short answer is not that we have been able to identify. We do know that there are some blood cancers that run in families, but they're so rare that it's really hard to get enough people together to say that, yes, there is a familial or genotypic reason in blood cancers. If we take a page from breast cancer, definitely the answer is yes. So in breast cancer, BRCA1 and 2 are genes that can be passed from a parent to a child. We don't have that in hematologic malignancies, or we haven't identified that yet. And we don't see that pattern as one might see in cancers that have BRCA1 or 2.
To better understand that, are we storing blood, tissue, and so forth as part of a biobank to help down the road understand these questions?
Absolutely, and that's a really key part of research, and being able to store those samples and be able to have people participate in giving their samples for research. And that's a really key component to any of the work that goes on in a research facility.
Another question that's come in is about support groups. These are relatively rare malignancies, and so patients may not know who to talk to for support when they're going through treatment. How is that happening in UAE?
Yeah, it's a great question. I'll be honest in saying that I think many people are very private about their diagnoses, and support groups do exist, but it does require challenging a little bit of social convention and culture for someone to participate in a support group. That's not to say that there aren't any. There certainly are, but it's something that really requires courage and the willingness to be open about their condition. It's not for everybody. Now, having said all of that, the biggest support group that anyone has is their family. And second to that is their care team. So as physicians, as nurses, we spend a lot of time supporting our patients, and maybe not having patients talk to each other, but certainly tell patients about others we've taken care of and how well they have done, and to help alleviate some of those concerns.
Next question is, are there any novel or emerging treatment approaches for blood cancers?
Absolutely. So some of the ones that I'm really excited about are in a technology called CAR T therapy. In CAR T therapy, what we as humans and scientists have been able to do is really take a T cell and reprogram it. We have been able to find a way to introduce molecules on the surface of the T cell that take it and then allow that T cell to recognize cancer. That's CAR T therapy in a nutshell. It's phenomenally helpful in diseases like lymphoma and multiple myeloma. So that's one area that I'm really excited about, and we're seeing great results, especially in multiple myeloma. The other area is these, what were called bispecific antibodies. So an antibody recognizes a foreign item from the body. But what we've been able to do is re-engineer it so that it doesn't just recognize one molecule, it actually recognizes two. And what that does is bring those two things together. So the therapies have been designed to recognize cancer on one side, the immune system, the normal immune system on the other, and bring them together. And the whole idea is to get that immune system to recognize cancer and kill it. That's another area that has started in multiple myeloma, but now has gone into, for example, lymphoma. So these are areas that in the next 10 to 15 years are going to be actively investigated and developed with even better treatments.
Preliminary data for things like CAR T therapy,
Yeah.
What's that doing to survival?
Oh, it's phenomenal. So one of the treatments that I'm very excited about is for multiple myeloma. And I still remember the day that I saw the data. I was in the room when it was presented at one of our national meetings. And it was 2019. Just to set the stage, multiple myeloma can be treated with a variety of regimens, and people can live a really long time with multiple myeloma. But unfortunately, at some point, the disease stops responding. With an average of about 6 different treatments, the likelihood of responding to number 7 is very low. But in 2019, with CAR T therapy, those people who have had on average 6 different therapies all of a sudden had 90% response rate to CAR T therapy. That is massively important, because otherwise these patients would not have had much response with anything left. So now all of a sudden we have something that works in people who've gotten lots of treatment, and it works really, really well. Not only that, it works for a long period of time. So now we take that idea, and in the last 4 years, more clinical trials have been developed and bringing it sooner. So why wait until somebody's had 6 different treatments? Why not do it after number 2, for example? And maybe you get better responses. That is, I think, really promising. And that goes also for the bispecifics. We're seeing some great response with the bispecifics in patients who have received lots of other therapy, but now we're testing the idea of starting off with bispecifics in combination with something else.
A great session today with
thank
Dr.
you.
Mastaqim Siddiqui, Chair of Hematology here at SSMC. Wonderful conversation. I'm enlightened and encouraged by all the advances that are happening in the treatment of blood cancer. Yesterday, again, World Blood Cancer Day, so we're happy to continue talking about this. And it's good to know that at SSMC, we're thinking about a holistic and comprehensive approach with state-of-the-art techniques. Thank you, Mastaqim, for leading the charge.
My pleasure.
We'll conclude our program today and see you next time.
Thank you.